Hello, everyone. Hello, my name is Guto Giordani from São Paulo, Brazil. I am super happy to be here together with you guys recording this presentation. I'm sorry about that, but it's going to be impossible to be with you guys live. I have a very important family time during this weekend, and I hope next time I can join you guys not only live online, but personally in the future. And it will be a great pleasure for me. But for now, I am going to record this presentation because I really want to be with you guys in this amazing program. So Todd, Chris, Otavio, Dani, everybody, thank you so much for this amazing invitation and opportunity. And I would like to take these 30-40 minutes to discuss a little bit about gummy smile and how do we treat patients with gummy smile, because this is really common in the office and we have different diagnoses. So every time that we take a patient, and this is a huge reality here in my office, every time that we see a patient with gummy smile, we really need to check all the possibilities, because when we face a case, gummy smile patient, we really need to understand if we have like a problem with the bone, lip, muscles, maybe the size of the tooth. And if we make a mistake in the diagnosis process, we really can give to the patient not a very nice and a good solution, because I see on Instagram and Facebook, also during congresses, that we are sometimes over treating the patients because of a wrong diagnosis process. And it's really important to first understand when you need to treat, how you are going to treat, which is the therapy, if it's a interdisciplinary treatment or not. So I will take this opportunity to bring one case to you guys, or Anna's case, to discuss a little bit the topics and how do we treat these kind of patients nowadays here in Brazil and in every place that I have the opportunity to treat patients. So let me just give you the context. Okay, this patient we treated in Romania together with a very good friend, Florin Kofar. And this patient came to us, first of all, to extract the tooth, okay? Because this patient came with the diagnosis of one single center that we had to extract, okay? And when Florin came to me, and when we started to discuss this case, he just asked me, Gustavo, can we extract this number 11? Sorry, I think in US it's number 8 or 9, but here in Brazil it's the number 11, is the central sizer of the right side. And I asked him pictures and tomography. And when we saw here the initial picture, you see that it's a very simple situation thinking about soft tissue. And when you see the tomography, it's also a very comfortable situation thinking about the amount of bone. So when we saw these exams, I said to Florin, it's a very simple case. We just extract, we place an immediate implant, we do all the treatment that we know how to do it for years, and it's a very comfortable situation. Let's move on. But the discussion is not only about the intraoral image. It's very important to check the face of the patient, because if you think about like the immediate implant indications, you will think about residual bone, okay, which is the first topic. If you have bone in the apical and palatal area to place the implant in the correct predisposition, this is the first topic. In our case, we have it. So it's a comfortable situation again. And if you think about the soft tissue level position, also we have a very comfortable situation, because when we don't have soft tissue enough, I mean, when the tooth that you are going to extract you see a recession of more than 4 millimeters comparing with the ideal level, let's say, the contralateral tooth, your future rehabilitation, but the ideal level. If you have a recession more than 4 millimeters, you have a contraindication. But when you have soft tissue in position and bone enough to place the implant, yes, perfect. We have the immediate implant indication. So in this case, in Noana's case, yes, we have it. Perfect. But again, let's think about the global situation. Let's think about the project. Let's think about the treatment plan, and let's understand the face of the patient. Because I showed you guys a tomography and a soft tissue reality, an intraoral situation. But when I show you guys the smile of the patient's face, I think everything changed, no? Everything will change 100% because this is a gummy smile patient. And when you need to extract a tooth in a patient like this, maybe it's not the right time to extract and place an implant because her chief complaint is the gummy smile. So I really need to think about what we have to do to solve the patient's problem, the gummy smile problem. And then I will understand when is the correct time to place that implant according with the final situation. So when you take a patient like this, a gummy smile patient, you can have 3 different diagnoses, okay? The most common, let's say like that. Vertical maxillary bone access, upper lip hyper mobility, upper lip hyperactivity, and we can have also short teeth, so altered passive eruption. Of course, you can have like different diagnoses. They're not so common, like short upper lip, dental alveolar extrusion diagnosis that we don't have here. And we have in this patient the 3 most common diagnoses: vertical maxillary bone access, upper lip hyperactivity, and short teeth. So perfect. How do we start this case? Because understanding that we need to extract that tooth, we really need to move on to an interdisciplinary treatment first, then we think about that. If it's not possible to keep that tooth, we need to extract, but it's not the time to place that implant. It's the time just to extract, go for like a socket preservation, do all the movements that we need, and then we move on for the late implant. But if it's possible to keep that tooth, we are going to do it. Because let's think about the possibilities here. First of all, we always do videos. I learned this from Florine. I learned this from Christian Coachman and all the DST group. It's very important to see the motion. It's very important to see everything moving. And we always ask the patient to relax the lip, to stay like this, okay? To see the central incisors, to see the exposure of the central incisors. With that and a tomography, a craniofacial tomography, we can detect if we have a vertical maxillary bone access. We always ask the patient to smile, to move a lot, because with that, we can see the upper lip hyperactivity. Normally, we have up to 8-9 millimeters from the relaxed position to the maximum smile in a normal situation. When you have more than that, 9-10 up, you can have a upper lip hyperactivity. And also we see tooth proportion. And in this patient, we have everything. So to understand how do we move it, it's really important to move on to design. And this is the philosophy of treatment that we do today. We always design first to understand what we are going to do and to understand if the patient wants that treatment. Because imagine, okay, vertical maxillary bone access, you can move on to orthognathic surgery, you can move on to anchorage, skeletal anchorage with mini plates or mini implants. You can do both, like ortho or ortho surgical treatment. How do we define this? How do we move into ortho or to orthognathic? Depend of the movement. And of course, depend of the professional you have in your team. I mean, if you have like a very good ortho and the movement is just vertical, okay, it's not anteroposterior movement, you can move on to ortho if you have like a very good professional together with you. But if you have a problem that we need to move forward or back the maxilla, then you really need orthognathic surgery. But when it's vertical, you can do or with skeletal anchorage and ortho, or with orthognathic surgery. But again, imagine if the patient understand that, but the patient is okay, I don't want that. Can I just be better with, like, let's say, small crown lengthening, just a little bit of Botox? You can do something not to compensate the problem, but just to make the patient a little bit better. And we need to discuss this with the patient. So we always start with the design, and we have tools for that. So you can move on like to the raw DSD, like the DSD that we learned many years ago. You go to the keynote and you start to see proportion. I mean, you can take like a very well positioned tooth and you can just draw a line and understand if you move the soft tissue up, if everything is going to be okay. You can use different softwares to see the images. Here we are in Exocad, and we are just checking everything internally with the STL file of an intraoral scan and a DICOM file from a tomography. We are just superimposing the images and check how many millimeters we can cut and how much we have of enamel under the soft tissue. You can see that. And you can use also different softwares like this one, SmileCloud. Then you can do the same. So you can check proportions. You can check how much you can cut, and everything is going to be easier for you thinking about diagnosis. And you can transfer those measurements to a software that can simulate the treatment, and you can show this to the patient. Here we are in SmileCloud, transferred all the measurements from the details we showed before, and we are just using STL files of natural tooth, showing the patient the final design, let's say like that. And when the patient see the design, the patient can say, okay, Gustavo, I like that, but this is not 100% for me. I still think that I am a very gummy smile patient. So let's change the treatment. And you can see here a simulation of a vertical maxillary bone access treatment, thinking about maxilla impactation, okay? And also a crown length and changing the format of the smile, okay? You can show this to the patient and say, okay, what do you think? Why is nice to do this kind of design before? Because you don't touch the patient. You don't touch the expectation of the patient using the mock-up like before. When you show this to the patient virtually, you have the best possibility not to make a mistake using the mock-up, because the mock-up is a huge experience. And also we learn from Gofar and Coachman, how do we use that? It's very important to motivate the patient using the mock-up. So we really need that shot. So showing the patient before virtually, it's the best possibility. So when we showed this to Oana said, Gustavo, Florin, this is super nice. I like this. I really like to change all my smile, and I don't want to have like a gummy smile anymore. So perfect. When we see that this is the way to go, we just compare, okay? You can see here in the left side of the screen, the short teeth treatment, just using like a crown lengthening, extracting a tooth, placing the implant, doing some veneers. And in the right side of the screen, you can see all the full treatment, let's say like that. Ortho, skeletal anchorage, perio treatment, implant treatment, and veneers. And when the patient said, okay, this is nice, I like it, Let's move on to that. Then we go to the mock-up, because now I have the possibility to really bring the mock-up effect, the motivational mock-up, as we learned from Christian, and with bisacryl composite, with soft tissue composite, and with black markers, we can create that illusion doing videos in the left side, in the right side of the screen. This is you. This is you at the end of the treatment. What do you think? And this is a very powerful tool to motivate the patient. So what do you think about? This is you, and this is your better version, let's say like that. And this is really amazing. And when the patient really see that and motivate herself, we can move on to the treatment, and we can explain the patient all the steps we need. So this is a very important question now. Can we keep the number 11, the central? Yes, during the ortho, let's try, because our treatment solution for that case, our treatment option for vertical maxillary bone access will be maxilla impactation using ortho and skeletal anchorage. And we really need that tooth, because that tooth is going to be the vehicle to bring everybody to the apical direction. If I extract that tooth now, I'm going to lose that vehicle, and I'm going to really bring me difficulties at the end of the treatment. I'm going to need a very huge crown lengthening at the end. So we are going to try to keep that tooth. So let's move on, and we place our mini plates. I'm going to stop here, and I'm going to create a big parenthesis here, because I really want to explain how do we do with mini plates. It's a huge and amazing skeletal anchorage. Also, you can use mini screws, but when you think about a very powerful tool and a very, let's say, good tool for different kind of movements at the same time, mini plates are really incredible, because the versatility that we have with this device, it's fantastic. So what do you need first? You really need a good system, okay? This is a system that we have here in Brazil, but also in US and in Europe, you can find very similar systems. You can find jail. Jail system is really fantastic. This is the system I use when I go to Europe. It's the system that I use in Florin clinic. But we just need all the pliers to bend the mini plate, and you need a very nice kit of screws, because when you are going to place that mini plate, you really need everything that brings you stability, you know? So what do you usually use? We usually use mini plates of 2 millimeters, okay? And we use screws of 2 millimeters. 5 to 2 millimeters is more than enough. I like a lot self-tapping screw, okay? And we really need emergency screws, which are screws that we have, they are a little bit wider, like 2.3. If you don't have a perfect stability, you just remove and we place the 2.3. We like to use 3 screws per mini plate, and this is really, really important. So thinking about anatomy, every time that we are going to place a mini plate, you really need good bone quality, okay? So when you are going to put your mini plate in the upper jaw, in the maxilla, we really need to place that mini plates in the pillars area. You have the zygomatic pillar and the canine pillar. And those are very important pillars, because if you try to place the mini plate like in the premolar area, you will find a very bad quality of bone, because you have the sinus there and it's not the place for the mini plates. So when you go to maxilla impactation, we like to use 4 mini plates, 2 in the canine pillar and 2 in the zygomatic pillar, because the mini plates are not devices that we are going to work using the osseointegration process. They are going to be there and we are going to fix, thinking about like a rigid process of using screws. So don't think about osseointegration. They really need good bone quality for that. In the lower jaw, it's a little bit more comfortable because we have like usually a very good bone there. We can use the external oblique ridge or you can use the ramus, and you really need to be aware of the teeth roots. So it's really important to take a tomography from your patient and to check not only the roots, but also the alveolar nerve and where is the maxillary sinus. The sinus is not a problem. You can go with your screw inside. You're not going to create a problem for your patient, but you really need to check the thickness of that bone. Otherwise, you're going to try to fix your screw and you are not going to have a very good fixation. So always check the tomography to be aware from the anatomy that you don't want and to take a very good bone quality. So you need, if you're going to place the mini plates in the upper jaw, you need a tomography of the upper jaw and the lower jaw the same. And you're going to check here. Look at the roots. You really need to be out of that. You really need to be aware from the alveolar nerve. You really need to think about where is the cortical bone to have a very good stability and so on. Okay, so we normally communicate with the ortho like this because the position of the mini plates are not decided by the surgeon. They are ortho devices. So if we are going to do like an impactation, you really need to bring space for the ortho. I mean, if you're just going to do distalization, you really need to be in the pillars, okay? Using the pillars in the maxilla, and you need to be a little bit more to the distal. So you're just going to bring an easy movement for your ortho. The same when you go to mesialization, you just go a little bit more to the mesial, so ortho can just do the movement a little bit easier. If you're going to do intrusion, like in our case, you really need to bring space. I mean, you are going to place your mini plates a little bit more apical, so the movement can move on, and then the ortho can work in that space. Extrusion is the same, is the opposite direction. And of course, if you are going to expand the arch, you really need to be away from the bracket area. So you give space to the ortho so the ortho can do the movement. Important details, okay? The surgical technique, we really recommend to use tomography. And if you want, just bring this to reality, printing the models, okay? Because you can bend the mini plate before the surgery. You just put the mini plate in the perfect position. You bring space for the patient to clean. You just understand when you are going or where you are going to do the incision, and you move on to your surgery in a very easy way. Of course, we take that mini plates, we go for sterilization, and then we ask the patient to come back for the surgery. So details here, guys. First of all, the incision of the mini plate needs to be related to the bend of the mini plate. What do we usually do with the mini plate? We do like a 90 degrees bend. Why? Because with that, the patient can clean that area. If you are just going to place the mini plate and you torque the mini plates for the ortho space, patient will create there like a pocket. Patient will have difficulties for the hygiene process. And this is really important. The patient needs to have space for the cleaning. And if you don't give the patient that space, you can have some inflammation, some infection during the treatment. So please do this 9 degrees bend and this incision related to the 90 degrees. So we usually try the mini plate on top of the soft tissue. Then we just do a small incision, bringing, let's say, a small blood plot to go for your incision. It's really a nice tip, because when you do that, you remove the mini plate out and then you just go for the incision. Why we do that? Because when we suture, you really have the perfect room for the suture, and the mini plate will be there, easy to clean, okay? Then we always go for 3 screws, not because we like, it's because when you go for the literature, when you check all the papers of mini plates, you will see that when you have only 2 screws, you lose more mini plates. When you have 3, it's really stable, okay? Then always check the passive adaptation. You really need to have a perfect passive adaptation. That's why bending the mini plate, adapting the mini plate is super, super important. Space to clean, we already discussed this. Ortho distance, remember, it's a device to the ortho treatment. So you really need to give the patient or the ortho, the professional, to work in the perfect position. So again, if you are going to do intrusion, you really need to have space for that. Otherwise, ortho cannot do that movement. And again, you really can adapt the mini plate position according with the anatomy there. I mean, if you're going to use the canine pillar, take care of the canine, because sometimes you don't see the canine and then we drill to place the screw and you can damage that root. So really important step, okay? So when you think about checking the tomography, you see the same. You see here, passive adaptation, the screw there, away from the tooth, everything that we need. 90 degrees bend, space to pay for the cleaning process, everything working very well. Let's just check a video. Let me remove the sound. Let's check the video here. You see, we are placing here 4 mini plates for ortho intrusion. You see that we pre-bend the mini plate. We just hold that mini plate there and we just do a small incision. You see that with this small mark, you can remove the mini plate out, and then we just go there in a very flat and linear incision. I don't like to do like 2 small incisions for the mini plate. I really like to open, to check, to see the perfect adaptation. So when I go for 4 mini plates, I just do 1 incision in the right side and 1 incision in the left side, okay? Then we are just going to go for the periodontal elevation, and it's a total flat, okay? We don't preserve the soft tissue there. We just want to see the bone. Of course, guys, take care of the delicate process. It's really important to be very delicate in this surgery. Okay, trying the mini plate. We are just holding in the mini plate in position. You can do small movements there to, again, create a perfect passive adaptation. We hold the mini plates with 2 instruments, okay? That's why it's super important to have a very good assistant. And then we go for the screw in the middle of the mini plate. We hold everything perfectly in position. And here, guys, you see you have the 90 degrees bend, the relating position of the incision and the bend of the mini plate. And you can see that it really works very well. You will see the final suture. So doing the next screw, medial one, then we are going to apply torque there to have a very good fixation. We do this again in the central screw. We do again in the distal screw side, and you see here that it's really rigid. Okay, so we are going to place here now the second mini plate, and now it's a nice opportunity to discuss the design of the mini plate. You see that we are changing the design of the mini plate, and I really don't like that design. I like a lot the T design of the mini plate. It's really fantastic. Not only because it's really nice to adapt in the pillar areas, but also you don't need to open a lot the flap. Because when you try to use like a L or a different design of mini plates, I see more difficulties. It's just my experience talking here, and we did like thousands of mini plates here in Brazil. So again, a T design, it's really fantastic for the anatomy of the maxilla, okay? You see here, I place the mini plates, and you, again, in the final part of the surgery, you can just do the small bend, put everything in the perfect direction, try to be parallel to the tissue, because with that, you're not going to disturb the cheek, you're not going to disturb the soft tissue. Be gentle with the movements, but bring the device to a very comfortable situation, not only for the patient, but also for the ortho. Bring this device to the perfect ortho position. Great. Now you clean everything, you check the screws, and we do our suture. You can use resorbable suture, you can use non-resorbable suture. It's up to you, okay? Here in Brazil, I like to use resorbable suture because it's more comfortable for the patient after, but we know that it's not easy to work. And if you want to use like polyamide, polypropylene, it's really a very nice suture to use. So I check the screw stability. When everything is there, I go there and do my final sutures, okay? So perfect. We check the tomography. Everything is okay. Away from the tooth, away from the nerve, everything is nice. And one very nice tip, guys, relate the incision to the band of the mini plate. You see here in the right side of the screen, a nice plate, and you see here in the left side of the screen, not too good mini plate. Why? Because when you suture like that, like the red one, you will going to create a pocket, and you can have like food impactation there, bacteria impactation. So with that, the patient is going to have more difficulties to clean, more difficulties to keep that mini plate, and infections are very common in this kind of patients. You see here in the lower jaw, the same. When you have the incision related to the mini plate, when you suture, everything is there. When you don't do that relation, really, look, we are going to suture here, and you're going to create like a pocket here, and this is really not nice. So always check this, and this is really, really important. In our case, we did that mini plate, and we start all the movement with Johnny Barbum, our ortho in Romania. I don't know if you guys remember, but we started with 3 hooks. Now we have 2. The movement is going up. Of course, they need to control the vertical. They need to control the condyle position. This is really important, and it's a huge conversation, not for now, but really important always to check everything. And at the end of the ortho treatment, Johnny asked me to do a small crown lengthening because he really needs to see the CJ. And again, as I learned from Christian, we like to use a lot PerioGuide. PerioGuide is an amazing tool. And again, thank you, Christian, for that, because this is really fantastic and changed a lot the perio surgery. Because combining the intraoral scan and a DICOM file of tomography, we can just see perfectly where is the CJ, and we just design this template, the PerioGuide, to cut the soft tissue. You can use blades, you can use laser, you can use electrosurge to cut the soft tissue. Depends of what you like and what you have in your clinic. Everything works very well. and depends of your skills. I like to use a lot electrosurge for that. It's really simple and fast, just to cut the soft tissue perfectly where Johnny needs. Imagine, guys, if you need to do this freehand, it's not impossible, but thinking about predictability, when I really want to have the CJ perfectly in position, this perio guide is really incredible. Actually, everything that I do in my office here, it's guided. I learned from Christian and from Van Doren and from many mentors I have. When you go guided, when you go to digital, you see better. You check the structures better. You apply your technique in a more predictable way. So as experience, I get more guided I go 100%. After that, Johnny just finished the ortho, and here it's our patient after ortho. You see, all the vertical is controlled. The impactation is there. And now the patient is ready for the final rehabilitation. You see here, superimposing tomography and intraoral scans, you see the movement we got around 10, 12 millimeters of intrusion. And now the patient is ready for the rehabilitation, the final rehabilitation. And of course, now it's the time to extract the central, because this brave tooth, we always check it during the treatment, and he's there to be extracted now. But to do that, we are going to do the second mock-up. Why we do that? Because again, we need to check. It's not only to motivate, and it's really important, but also for the team to check if the forms are okay, if the patient is happy with the design. 1.5 years, 2 years after, we need to check again and to motivate again the patient. But now a completely different mock-up, without black markers, without gum composite. Now it's time to do everything in a clean way. And again, now it's time to extract the tooth, because look what the tooth gave to us. The impactation is there. So I can move on now to all the steps we do. And we published this in QDT last year. All the steps that are necessary to create this stability in immediate implants in aesthetic zone. So thinking about the steps, you need to have indication. We already discussed about that. Soft tissue, bone, and the face of the patient now it's in the correct position. So we have the perfect indication. Let's move on for the guided surgery. Again, one more intraoral scan. We need now the STL file of the mock-up, because the implant will be related to a final rehabilitation. So we need that STL file to bring together to the planning, and also the tomography. Then we can go to the software and we plan. This is the M software from MIS. We are just planning the future implant position and selecting the prosthetic component. And we decided here to use the Connect, which is a prosthetic component from MIS developed by Nitsambi Chacho. It's a very nice intermediary abutment. Actually, it's just to bring the concept of a bone level implant to a soft tissue level implant in the level that you want. It's just to bring the platform outside of the bone, which is fantastic for bone stability and not to connect and disconnect all the time internally, okay? So we move on to the surgery process. We extract the tooth number 11, the right central incisor. And of course, we need to be, try to be as minimally invasive as we can do, okay? If you have like forceps room, you can do round movements. Otherwise, you can move on to extraction devices, periotomes, but try to be as delicate as you can. It's really, really important. After that, we are going to place our guided implant. Again, guided is not the solution, okay? But it's really predictable, because when you see everything inside the software, you can select the implant position, you can select the implant size, you can select the prosthetic component, you check everything related to the final situation. And of course, you bring this to reality in a guided surgery. I don't want to stress myself during the surgery thinking about the implant position. This is not for me anymore. And I think in 2022, this is really something that we can avoid. Implant position is very important. And if you have a guide to bring that position you plan to reality, why not to use? It's really fundamental for me. This is something that I'm going to do 100% in my cases here in the clinic. And of course, the system is also very important because you can find implant systems in the market that gives you a lot of easy drilling process. I mean, you can find systems that are very difficult, that are old, and you cannot place the implant 100% guided. And what I mean, place the implant 100% guided, it's put the guide, just hold the guide in position, drill everything using the guide, and place the implant using the guide. Doesn't make any sense to place the implant without the guide. And a 100% guided system is bringing your implant inside and not touching the implant, or the implant not touching the bone before the insertion tool touch the metal sleeve. If you have contact with the implant and the bone without metal connection, you are going to place the implant freehand. And I'm not going to say that this is wrong, but this is not guided. So we really need to have a system that allows you to be 100% guided. So here, after the soft tissue process of the soft tissue steps, we like always to work with connective tissue graft in the buccal area, always packing biomaterial between the implant and the buccal wall. And here we are placing our connect. This is the provisional that we milled using PMMA right after the surgery. And this is the situation after 4 months. Long story short, this is the situation after ortho, implant, and a provisional. Now it's time to finish our case. And this is the smile of the patient 4 months after the surgery. And you can check here the tomography. Look how nice it is when you work with all the steps correctly. You see that we have the implant there inside the bone. You see the bone there in the buccal wall. I mean, the biomaterial there stay stable and everything is there, no problem at all. The connect is protecting everything. And now we can just switch from the provisional to the final ceramic. We decided to do a small crown lengthening at the end of the treatment. And this is the technique that we also published in QDT last year, which is the technique that we just do a small vertical incision. So we can, in a flapless way, cut the bone without opening the flap. And by packing the cords and doing the preps, we scan and we put the provisionals inside to hold the soft tissue position. It's just a small incision to bring space for the provisional. And instead of cutting the tissue, we are just splitting the tissue and bring more tissue to the proximal area. It's a very nice technique when you don't need to cut a lot, when you have thin soft tissue, when you have thin bone, and we are going to do aesthetic rehabilitation. So if you want to learn more from that, the QDT article is available for you guys, okay? So we are now monitoring the preps, again, using SmileCloud. We just take the STL file of our prep scan and the STL file of the work mockup, okay, the final design. And we are just superimposing the images here to check if we have space enough for our future restoration. This is the soft tissue anatomy after removing the provisional, and we are going to finish our work here. Florin really likes to use Mojo to finish the rehabilitation. we are just recording all the movements of the patient and bring this to the lab. Long story short, this is a provisional meal using PMMA, again, to bring the healing situation to the patient. You see here that the provisional will just push the tissue to the correct design, and we are just going to again change the material. After 1 month, we change from PMMA to ceramics milled restoration, and here is the final situation of our patient. Initial situation here, final situation in the right side of the screen, and you can see here, we are just playing with the images, the movement we did. Treating the patient with vertical, with skeletal anchorage for the vertical problem. The short teeth we manage using crown lengthening and veneers to finish everything, okay? You see here just the details of the tomography of the implant, okay? The 0 is the initial situation. Number 1 is the situation after the auto treatment, after the maxilla impactation with mini plates, the 4 months after the surgery, and 2 years after the surgery. Everything's there, everything's super stable, and this is the smile of the patient. Initial situation and final situation. Look how nice it is. How can we manage the gum smile using simple techniques, not super invasive techniques, and the result is actually very acceptable in our point of view. So initial situation, after ortho, after impactation, and after rehabilitation. This is the initial and final design there in the picture. Just a conclusion, guys. When you have like a very soft tissue or a gum smile patient, thinking about all the diagnosis, because the tool that we have, like I do only crown lengthening, sometimes is not the perfect tool for that patient. You really need sometimes ortho, orthogenetic, sometimes you need Botox, sometimes you need lip reposition. This patient, it's a very nice patient for like lip reposition, for Botox, for fillers, but she doesn't want at the end of the surgery or at the end of the treatment. But you can check, and sometimes you apply that, that treatment to the patient, and you really need to, you can fix a lot of problems, but everything needs to be related to the diagnosis process, okay? So you are going to have the possibility of read this article, because the article is ready to be published in QDT next year in 2023, and you can see all the step-by-step there, okay? Guys, one more time, thank you so much for your time. I hope you enjoyed. This is my Instagram. I put a lot of tips there if you want to check. This is my email if you want to be in contact with me. Todd and all the group, Christian, Dani, Octavio, everybody there. It was a huge pleasure to be here. Hope to see you guys live and personally in the future. See you soon, guys. Bye.